My name is Ellen Matloff. I'm the president and CEO of My Gene Counsel. We're a digital health company, and our main mission is to make sure that patients and providers are getting reports, living lab reports, immediately when they have genetic testing, and these reports update over time. So you can imagine that the 21st Century Cures Act was of great interest to us. And when we started to dig into it, we found that it was evolving and it was murky. And so we searched for some of the people providing leadership in this area who are helping us all to forge a path. And we were very lucky to get John Richardson, Kim Linthicum, and Cori Feist to speak to us today. John is the Director of Policy and Government Relationships for NSGC. He oversees federal advocacy, state licensure, payer relations, and policy support. He's had roles as the Executive Director at the Physician Hospitals of America and Director of Government Relations for Smith Buckland's Healthcare Practice Group. So John understands the needs of healthcare organizations. Kim is the Senior Vice President of Government Affairs and Public Policy for Myriad Genetics, where she oversees federal and state government affairs activities to ensure access to the company's advanced diagnostic services. She is also a leader in public policy development in the clinical lab space and has a deep understanding of legislative strategy and healthcare reimbursement policies. Cori has 20 years experience as a clinical genetic counselor at Oregon Health and Science University in Portland, Oregon. She's been active in education and policy making at both the state and national levels, and is the former chair of the NSGC Public Policy Committee, and she's the current liaison between that committee and the NSGC Advocacy Coordinating Committees. So as you can see, we're very lucky to have these speakers with us today. Let's talk about our agenda for today. As you may know, the Cures Act is a huge act. And so we're going to really narrow our focus today and discuss an overview of the Cures Act only as it applies to genetics and genomic services. The stakeholders that must consider this legislation include laboratories, genetic counselors, physicians, health IT developers, and payers. So that's why there are 800 of you signed up for this webinar today. Also, what to consider in formulating plans for compliance and to avoid information blocking. And we'll talk about some of these terms today and what they mean. And also how the landscape may evolve over time. So thank you so much for joining us. We're very lucky to have these speakers with us today. And I'll now turn it over to our first speaker, John Richardson.
Thanks, Ellen. And welcome everyone. Appreciate the opportunity. So here are just some helpful definitions that we thought everyone should be familiar with when we're talking about this whole Cures Act and what it means for the information exchange of healthcare. So actor, I think, is a big issue that everyone should familiarize themselves with. So healthcare provider is defined in a very broad sense. It means a hospital, a laboratory, a physician practice, a physician, nurse practitioners. Many different practitioners are listed under the statute. And so most people that are providing healthcare services are considered actors. The interesting thing for genetic counselors is that they're not actually listed in the statute. They're not excluded either. So I think that for the benefit of these conversations, genetic counselors should assume that they're going to be considered an actor. So the 21st Century Cures Act, it was a very large bill, did a lot of things, a lot of great things, provided funding to accelerate medical product development. It addressed the opioid crisis in a big and real way, improved mental health service delivery. And what we're really going to talk about today is empowering patients with their health record in a modern kind of health IT economy and environment, really to improve access to health records to patients in easy to understand in a secure and to be able to upload that in an automatic way. And that's really also a key thing to keep in mind, that we're talking about automation here in terms of people accessing their medical information. So the final rule in regard to kind of electronic health information, it's really the focus is to on transparency. So cost and outcomes of the care, to have competitive options in getting medical care. So more transparency there as well. Adoption of standardized methods, access to the records, utilizing health information networks that can provide patient records via apps, and then patients having secure access to that exchange of information. It does not explicitly address genetic or genomic information. And it does allow information blocking in some certain areas, and we'll get more into that in a little bit. But really it's about transparency and having people empowered to access their health information. So I said, information is allowed. Basically, it's part of Section 4004 of the Act. You can interfere with patients' access, exchange, or use of their personal electronic information. It's considered an unacceptable practice with penalties for noncompliance unless these certain provisions that I'm going to talk about in a minute are met. And there are fines involved. The fines basically for providers have not been announced yet, but this is a serious business. And so if people should have access to this electronic health information, you need to allow it to be unencumbered. It went into effect April 5th for the providers, health IT developers, health information networks, and health information exchanges. So this is something that is now implemented and people need to be aware of and take seriously. There are some exceptions. And so, there's a privacy exception, security exception, preventing harm exception, and feasibility, health IT performance, fees, content manner, and licensing exceptions. What we're really going to do is focus on the preventing harm exception, because that's going to affect a lot of you and how you deliver information to patients. So the prevention of harm exception. This is really the one likely to most impact the genetic community. It will not be information blocking if an actor is engaging in a practice that is reasonable and necessary to prevent harm to a patient or another person, provided certain conditions are met. And the certain conditions are very important to appreciate and understand. Really, the objective of the exception, it recognizes that the public interest is protecting patients and other persons against unreasonable risk of harm, and that can justify practices that are likely to interfere with access, exchange, or use of the EHI. But there are four main requirements that you need to demonstrate that there is risk, that the exception can't be overly broad. It must satisfy one of the conditions under number 3, and it permits a patient to request and review. If you're going to information block, essentially the patient can request a review to determine really what harm would be in place if you were to block this information to that patient. So at the heart of the information blocking would be an organizational policy. So if you're going to block certain types of information, you have to have this policy. And for actors and healthcare providers, the organization policy is very, very important for you to understand and appreciate. You may have been involved in the development of some of these policies at the organizational level. Hopefully you were. If you weren't, you might want to contact your compliance office. If you're not aware of your organizational policy, definitely talk to your compliance office. If you think it's reasonable that's great. If you think it's unreasonable, then open up a discussion, because as Ellen mentioned, this is going to evolve. You know, in real world practice, people will have a greater understanding of what's really working, what's not working for both patients and practitioners. And so there may be changes down the road that will adjust to ensuring, you know, patients are receiving timely information that they can understand, reducing the risk of harm. But when there is this increased risk of harm, you know, there is a way to put some brakes into the process where patients aren't receiving information in real time. And so, you know, this theory of patient harm is really at the key of the organizational policy that may allow some of this information to be blocked. And with that, I will turn it over to Kim, who will provide some of her perspective in terms of laboratories and what they have to deal with regarding the Cures Act.
Thanks so much, John, and thank you to Ellen and the rest of the team for inviting me today. You know, I think that this is an issue that, as most have already noted, is going to continue to evolve. It's one that we have wrestled with. I think as a lab industry, there were some delays that were put in place. And so this April 5th date was a previous delay from a date that was last year due to the pandemic. You know, with regard to what is an actor and kind of how do laboratories fit into this, you know, some folks forget that we are providers in the space, even though that we are providing a service that's ordered by another clinician. And so we are actors under the rule, and we need to comply with these patient requests. I think an important factor that we've already received this as an advanced question, and what probably will come up a lot from folks is, are we required to push results out proactively when they are completed? And the answer is no. Results are not required to be proactively provided to the patients. However, we do believe there will be patients who increasingly are able or do request their results, and will be accessing those probably at the same time as the ordering clinician. So that's probably an important timing factor for you to understand. Patient portals are not required to be established. However, the overall goal of this particular law and regulation is to increase that sort of interoperability and the fact that information can really provide a lot of empowerment to patients. And so I would think that patient portals will be more likely in the future. The preventing harm exception that John walked through is also one that's had a lot of discussion as we've watched the rules be finalized. And it's really going to be directed by that ordering clinician. And it's something that the bar should be on a case-by-case basis. The idea that a particular type of lab test result will, across the board, be something that could cause harm is not likely to meet that exception. So it has to be that very much individual case-by-case basis. And I think as laboratorians, we'll be looking for the clinicians who have requested that result and are using it in the treatment of care of that patient to be making that case-by-case decision. The federal rule does not supersede state laws, besides the HIPAA privacy rule exception. So we all are familiar with kind of request for records and a designated record set under HIPAA, and that stays in place, but think of that as kind of the far end bookend. And so if a state law were to be in contrast with that HIPAA privacy, then HIPAA would take the place of it. As actors who may be operating in multiple states, which would be a lot of your commercial laboratories, folks operating across the country, we are permitted to adopt a uniform policy and procedure to implement consistently across the organization. So when we look at that and we look at various state laws that might impact the release of genetic test results or other lab test results, we can take that into account. What's important though is that that be in the standard operating procedure and policy of the laboratory and it be consistently implemented. So if you had a particular state that said you could not provide results in a certain time period, you could take that and apply it across the board, or a laboratory could choose to look at those test results on a state-by-state basis and apply those individual state laws, as they come down the line. Next slide, Dom. So again, being a provider, but being one that's an ancillary service that's ordered usually by other clinicians, I wanted to, touch on kind of how do we bridge that gap between laboratories and those who are involved in either ordering or discussing the impact of, genetic results with patients. Again, delaying results to patients just for the purpose of a clinician reviewing first will in fact constitute as interference under the final rule and would be a non-compliant act, unless of course there are those state laws that you would be looking to adhere to. So in this case, I feel like laboratories in some cases may be caught between the ordering providers, the ordering clinicians who are providing some education about the results, and the patients. And so we believe that education is really key to reducing some of this friction, which is another great reason, to participate in today's webinar, to really start that education, figure out ways that we can reduce friction and ensure that everybody has a good experience. From a Myriad genetics perspective, we've looked to add some notifications to our websites and ordering portals about the Cures Act and the compliance date of April 5th. Our test results are still sent to the ordering clinician first. We have no change in how ordering clinicians are basically receiving their tests under the rule. And our experience is that patients typically request a copy of their test results after first speaking with their provider. And when patients can't get in touch with their provider and may be anxious about their test results, they may be then requesting it directly from the laboratory. And I think that's probably where we see most of our requests coming from patients for lab results, is they've tried to talk to their physician or provider and they're not able to get in touch with them, either because somebody has gone on vacation, they have, a busy schedule and have not been able to get back to them. And that's where we get a lot of those requests. I do not believe that we have yet seen a huge increase in patient requests as a result of this particular rule going final. But I think in general, we have seen kind of a small increase over time. And we'll talk a little bit about that towards the end of the presentation on what we might be seeing in the future and what are some of those trends. So I'll turn it over to Cori now to talk more about how is this going to impact how a genetic counselor is practicing in the clinic. Cori?
Thank you. So I wanted to speak a little bit about some of the potential impacts of the final rule on clinical practitioners, including genetic counselors. I think it's important for people to understand that there is evidence that enabling patients to have open access to their own records actually improves the provider-patient relationship. It's also been shown to improve patient engagement. It improves their treatment and medication adherence and can remove some of the barriers to equitable treatment because it can allow patients to better understand their medical record. And this appears to be especially true for our patients who might have lower education or lower health literacy. Clinical genetic service providers, including genetic counselors, really do have a unique skill set that allows them to be especially successful in regards to the final rule. The priority of genetics providers has always been on communication with patients and patient advocacy. So the training of somebody like myself, a genetic counselor, really already allows us to meet the goals of the Cures Act. I know personally that my biggest concern was that I wasn't going to be able to get my patients' results back to them in a timely manner, that they might see the results of any sort of genomic testing before I did or before the physician who ordered the test did, that patients might misunderstand these results. But to be honest with you, that's really not anything new to us in the genetics field. That's something that we've been dealing with for quite a while. So what the Cures Act final rule is really doing is highlighting the importance of well-trained genetic service providers, including genetic counselors, who can help seamlessly transition and advocate for their patients. So I encourage you not to be fearful of the final rule, but remember that its ultimate goal is to give our patients the right to their own medical information and improve their patient experience. Next slide. So there's really two major ways that this is going to impact genetic services providers, including genetic counselors. Number one, how will it impact our clinical practice? And number two, how will it impact us from sort of a legal compliance perspective? So in order to successfully navigate the Cures Act final rule, providers, including genetic counselors, need to prepare our patients in advance, that they may immediately see the results of any notes or letters when they leave clinic. They may see lab results, including genetic and genomic test results, before their ordering provider or genetic counselor can. They could see pathology results. They could see imaging results. And now I realize that not all genomic and genetic testing is equal. A carrier screening test, for example, is not the same as a test result for a predictive Huntington's disease. So the responsibility of genetic counselors and other genetic services providers will be to work with their employers and their organization, maybe to create policies that respect the differences between certain results or categories of results. We have a different perspective and a different skill set than some of the individuals in our legal and compliance departments, and they may appreciate our feedback or our input in creating these policies. It's important that each of you who are working in a clinical setting reach out to your employer, whether that's a hospital or a medical facility or a private clinic, to find out how are they interpreting the final rule. It seems to be interpreted differently depending on the institution or the provider. So reach out specifically to find out from your legal or compliance departments, even your privacy office, what do they know about the final rule? What procedures and policies do they have in place? You may need to speak with your director of your laboratory or your pathology department, or even your electronic medical record or EMR heads to get more information to make sure that you are being compliant with your organization's policy. Next slide. In regard to the final rule's impact on clinical practice, I would recommend that you take a look at the American College of Medical Genetics and Genomics Point to Consider statement that was published in 2020. This is an excellent paper that supports patient access to their own healthcare information, but definitely advocates that information needs to be clear and useful to the patient. So for example, in this article, they state that results should be in a form that is reasonable and that a patient can understand and utilize. Test reports should be linked to a clinician's note electronically to aid in the interpretation of those results and clarify if a specific clinical diagnosis has been made. And since the interpretation of test results might evolve over time, for example, through reanalysis or reclassification of variants, new interpretations should be time-stamped, stating that they clearly supersede any prior reports. Next slide. The NSGC Public Policy Committee was asked to write a FAQ document for our membership. And in researching and preparing for this document, members of our task force interviewed several different genetic counselors who work in clinical settings around the US and just asked them, how is your institution or your employer preparing to comply with the final rule, or what policies and procedures do they already have in place? And we realized that everybody is doing something a little bit differently. And when we recontacted them, even 1 to 3 months later, sometimes those policies had drastically changed. And that's just a reminder that this is, again, an evolving process, and the ONC and Congress understands that. This is not a black and white set in stone quite yet. Perhaps it never will be. So I wanted to give you some examples of organizational policies and what they're considering to be exceptions to information blocking and how they're interpreting the final rule. This is not an endorsement in any way. But for example, there's an institution in the Pacific Northwest that uses an EMR called Epic, and their patients have access to something called My Chart. And so all labs, pathology reports, imaging notes are released to the patient immediately upon finalization. So once the provider or the laboratory releases those reports, the only way that it can be not released immediately is if at the time of ordering or the time of opening the chart note, the provider selects something called manual release. And you'll hear this a lot. Manual release means we have decided that we meet one of the exceptions for information blocking, and usually for clinicians, that's the prevention of harm exception. And we are following our hospital's protocol. And usually this in prevention of harm exception is going to be based on a provider's or an individual clinician's expertise and their personal clinician-patient relationship. And it's going to be on a case-by-case or patient-by-patient basis, and on a lab, at least for lab testing, a lab-by-lab basis. So you can't just blanket say any sort of prenatal genetic test result we are manually releasing. It has to be, at least at this institution, it has to be case-by-case, lab-by-lab, patient-by-patient. There is a facility in the East Coast that is releasing most labs and x-rays within 24 hours, although they do have some exceptions, and they've got a written organizational policy that states any sort of complex imaging, any pathology results, any sensitive lab results, for example, sexually transmitted infection results, especially for those under age 18, any pregnancy tests or drug screens, those will be released after 7 days. And then they have an interesting policy that is currently under review to make sure they're in compliance with the final rule, which is that all of their genetic tests are released after a 45-day delay. And again, that is probably going to change. And specifically, they've made a policy for Huntington's disease results that they will be paper results only. They won't go into an electronic medical record. And then finally, in California, there's an institution that does things quite a bit differently because their state law requires that abnormal results must be given verbally. And they have decided that any sort of prenatal genetic testing labs will be manual release. Pre-symptomatic testing results will be manual release, as long as the provider feels that it meets the prevention of harm exception. And any labs that are performed internally, for example, at their own personal genetic testing lab, will be delayed. They will not go into the electronic medical record until 20 days have passed. Next slide, and I'll hand it back to Kim.
Thanks so much. So we wanted to kind of tee up some potential kind of future issues. And I know we've got a lot of questions in the chat. We will get to those once we conclude these next couple slides. I think as everybody's talked about, we will expect future revisions. So the rule to impose civil monetary penalties for non-compliance has actually not yet been issued. So once that is issued, that's something for us to be reviewing and understanding how that's going to work. If folks are interested in kind of, filing complaints, there are ways to do that on the HHS website and can be done so anonymously. And again, I think how those will be adjudicated and whether or not fines are levied is still to come. I think in general, we're seeing an increased focus on consumerism and technology across the healthcare space. So this rule is really requiring interoperability through all of the folks in the healthcare space. And in particular, there are segments of the rule that we haven't talked about today that have to do with APIs, application programming interfaces. And the real goal here is to make sure everybody is talking in a similar language so that things can easily be transferred from one system to another, and that information about your health as a patient, as a provider, can be readily accessible and can be applied in various situations. So we'll see apps continue to be developed and really driven by consumer demand, I think, as well as provider and hospitals and other healthcare systems. We see, as I said, systems and practices relying heavily on apps. People really want to condense the information, make things easier on those patients and other providers that they might be working with in the kind of entire care continuum. And I think another thing for us to watch for is what payers might be doing. They may end up requiring that, there's a transmission of lab results immediately when they're complete for patient apps that they have. We've seen some questions about MyChart. We've seen questions about Epic in the chat. So again, these sort of systems are really meant to drive, and a rule is meant to drive people towards a common language so that the transmission of information will be standardized. There's a reference to electric health information. Again, this is different than a designated record set that might be requested under HIPAA. And so this is according to the US CDI kind of data set as to what is the information in the electric health record. And I think the other thing to be thinking about as we go forward is really health disparities, right? We've seen a lot in telehealth and the increase of telehealth during the pandemic to increase access to healthcare, but there are a lot of questions being debated in Congress right now about broadband access. So who has the smartphones? Are they getting the apps? Are they knowledgeable about those apps? Do they have that kind of dial-up internet? And I think you'll see a lot more pairing of apps and additional information driven to patients as we get more electronic and do more of these kind of telehealth encounters. So those are a couple of things we wanted to tee up for future conversations and directions and things that we'll be watching. We also have some resources on the next slide, John, that we wanted to direct folks to. And again, you'll be getting a copy of the slides. We've already shared the NSGC fact sheet, which is a great starting place for folks who want to dig into another level. In addition, there is an entire webpage that the federal government has put together on the health IT rule under the Cures law. And they have developed an entire section of FAQs, actually specifically to information blocking. Some of that is from a rather agitated lab industry that raised a lot of questions. We've had a number of meetings, with ONC to try to get clarity on some of these questions. So we've seen regular updates to that FAQ list, and that's probably, your best place to go as a trusted resource to try to get some scenarios answered. And with that, should we turn to some Q&A, Ellen? I'm not sure how we want to.
Yes, I think so. We have a lot of questions, and thank you to our speakers. Let's start at the top. Will Myriad Genetics establish a patient portal? And if so, will it provide results proactively or only if the patients request it?
So great question. For those who work with Myriad Genetics across several different spaces, you may be aware that you would get a different experience from us, whether you are in mental health, women's health, or oncology. So we do have some of our segments and our channels where we may release a result simultaneously to a patient through a patient portal. That tends to be on the women's health side, and the clinician is aware of that. We are definitely looking into patient portals. Mental health has seen a lot of activity with telehealth and with a demand and desire to understand genetics and the impact on medications. And we're seeing a lot of that, in oncology as well. So I think we have a TBD on whether we will have a uniform patient portals for each of our channels of business. But right now, to meet the compliance of this law, we are continuing to respond to patient requests for test results.
Thank you. And does the result concept apply if the patient wants their raw sequencing data?
So again, another great question. So I think this has come up more so, and it should follow under HIPAA. Raw sequencing data would not be part of that US CDI kind of data set fields that would be part of electronic health information. So we would manage that. Those can take a longer period of time to respond to. And we would manage that in accordance with the HIPAA rules and requests under, specifics of a designated record set. So I'd say it's kind of outside of this particular April 5th and compliance with electronic health information as I understand it.
Okay. And what if results are available, but there's information that's incorrect or missing from the report? Are we required to release those results upon patient request?
So one of the questions that's come up from laboratories that we've been working on is something that might be an incomplete results. And this may have to do if multiple different type of lab results might be ordered at the same time, and you had some that were complete and something that was incomplete. We're still waiting on some response from ONC with regard to that. I guess if you know that it's wrong, I'm concerned about that being final. And you know, we'd have to probably look at that and on a case-by-case basis as to how that would be handled.
Thank you. And do you think that because patients will be able to see these reports immediately, it will lead to updating the wording of genetic test reports to make the language more patient-friendly? Or do you think laboratories will team with digital health companies like My Gene Counsel that handle that part for them?
You know, I'm not sure. I think that's a great question to see how the space might evolve. I have not been involved directly in how we make the decisions for the words that go on our particular result reports. I know there is a lot of people at the table for that and a lot of consideration because, again, we are caught between both a patient and a provider, right? And there are certain levels of information that some providers want. There are others that just want to know, you know, positive, negative. Others want a whole nother level of information, you know, kind of behind that report. So I think that's a great question. And, you know, something that if folks believe that there need to be changes, this is a good time to kind of be raising those needs.
And I would like to add that one of the goals of the Cures Act is really to make sure that patient information is in an easy to understand and easy to utilize manner. That is the goal of the Cures Act and the final rule. And as the ACMG paper pointed out, really, we need to work together as a medical community and as a genetics community in general to consider exactly that thing. Changing our reports, changing how we write reports, changing the layout of reports to make it easy in a way that a reasonable patient could understand and utilize.
And a question along those lines, all reports are presently in English. So, and many people are saying they have patients that speak and read other languages. So is there any obligation to think about translation for interpretation reasons?
Again, as our last slide of future directions, you know, that's an access issue that needs to be addressed. And Congress is aware of that. Not everybody speaks and reads English. Not everybody has access to electronics. You know, I have a lot of patients who cannot afford a smartphone or internet service, or they don't use them, you know, maybe because of their age or their culture. Or they don't have access to them. I take care of a lot of patients who are incarcerated and they can't have those. So they still have a right to their medical information. So these are things that the Cures Act, again, as an evolving process, is going to need to address.
Along those lines, Cori, one interesting question is, my clinic works primarily with the Amish population who do not have access to technology. To comply with this act, would we need to mail patients, lab reports, clinic notes, et cetera, or just upon patient request?
Don, do you want to address that? I think this is specifically to electronic health information.
Yeah, and so I think that no, I mean, if they request it, then probably you should mail the information, but it really is the electronic interface that we're talking about. And so, you know, when we're talking about foreign languages, you know, I think the future is additional APIs that can be built into these platforms that would provide translation services, probably in real time, electronic translation. And so we really are talking about the electronic exchange of this information and, you know, empowering people to access it. And generally speaking, you know, you have these portals that have, you know, some entities and providers have had these portals for years and years, where you can go to their webpage and then, you know, put in your personal information and you can see, you know, a report. And so I think a lot of it will be maybe pushing to the consumer, to the patient, but a lot of it is the patient just being able to access it on a web portal, if you will. And so necessarily mailing, or that's kind of outside the current law. But again, I think that as we talk about disparities and trying to empower people with more information, which is the goal, then maybe things will change there.
We have a few questions directly about Epic, and basically that results aren't easily accessible to patients because they're scanned into the media tab, or that if you upload a PDF result and the genetic test result does not automatically flow into the patient portal, how will we handle these things? Do you have any insights or ideas about that?
I do know that health IT developers, including the Epic, the company, are working on this right now. So my institution uses Epic, and patients can only see the interpretation on their My chart, normal versus abnormal. They know that the result is in and is scanned, but they can't see it. That is not going to be allowed in the future. That is something that is going to need to be fixed. These health IT departments and EMR departments are going to have to work on that. Again, this is a work in progress. You know, we're not everything is set in stone yet. People are still trying to figure this out in the real world. It all looks great on paper, but we all know things work differently in the real world, and there's going to be some give and take and some trial and error.
So some of the questions are about other EHRs as well, and they're all going to have to find a way to work around this and make it possible if it's not currently possible through their platform, I would imagine. Is that right, Cori?
I believe so. And to be fully compliant with the Cures Act.
Yeah, and I would add, I mean, interoperability with the Cures Act is really important, where, you know, when I think we started out with EHR many years ago, interoperability was, you know, was on the table, and then that kind of went away in manners that, you know, they don't talk to each other company to company a lot of the times. And so hopefully all this will become more efficient as there's more focus on it. And again, it's these APIs that allow these different platforms to talk to each other, I think will help that immensely. But it definitely is an area where improvement, I think, will come and probably come sooner rather than later.
Interesting question about patients who request that we do not release their genetic test results through a portal because they're concerned about privacy. If they decline the use of EHI, should there be written documentation of this, in your opinion?
I don't know, I'd defer to Kim. Most likely you'd want to document that just to protect yourself, to make sure that, you know, a patient signs, you know, a document saying that they've kind of waived their rights to this information.
Yeah, and I think, again, that's probably handled in that kind of proactive dissemination of results, as opposed to the information blocking rule, which is responding to a patient request for results. In that case, right, you wouldn't have that request coming in from that particular patient likely. So I think as laboratories work to build patient portals, some sort of opt-out function, it probably, you know, needs consideration.
I also want to point out that if a patient signs up for access to their medical records, for example, our institution is considering just simply signing up for My chart as giving their consent to have their results put on the portal and viewed by them. So when we talk to patients, when we first meet a new patient and we say, would you like to sign up for My chart? We have to explain to them what it's for. Because I've had lots of patients who say, well, I want my CBC result, but I don't want my BRCA 1 and 2 result. And it's like, well, then don't click on the lab tab that says results are available. Because once you click on it, you're giving your consent to view it. And that's going to be very difficult for some patients. I can imagine there's going to be a lot of patients who maybe see something that they don't want to see. But the bottom line is, if you give your consent, and you're giving your consent to review your records by signing up for My chart and then opening up your message or the link or the lab result.
This is a really interesting question for those of us who are clinicians. How do we comply for partner or proband tests when one result fails under manual release and the other does not? Because of course it seems pretty obvious that if one person gets their test results and the other doesn't, that someone has tested positive.
I don't understand the question. When one partner fails?
So when they fail under manual release and the other does not. So for example, let's say you're testing multiple family members for a condition or even for carrier status, and one fails under manual release because they are BRCA1 positive, but the other one receives their test results telling them they've tested negative. How will we handle that within a family? Does that make sense?
You mean falls? Thank you. That makes more sense. So in almost all, I can't speak for all because I've only interviewed about 7 or 8 clinical facilities and university medical centers, but most of those, it's either the test category itself, because of a written organizational policy, they will all be manual release, or it falls upon the provider, the ordering provider, at the time of entering the order, placing the order before the lab is even drawn, to select manual release. So potentially I could understand what will happen is if the provider forgets to do that, like does it incorrectly, selects manual release for one person and not another. So again, providers are going to need to really pay attention and understand their organizational policy and the procedures and follow them. I think part of what will really be helpful is that you can't just click manual release for the fun of it. It does require in most EMRs that you answer some questions and prove why it would be considered an exception to information blocking. So that will hopefully be sort of a stop. Let's think about this for a minute. But I can see where errors would happen.
Yeah, and Cori, just to follow up on that, I know that my much more educated colleagues at LabCorp within ACLA have been working on some of the language within HL7 that would actually be very specific to the prevention of harm exception. So those that are, again, much more skilled on the kind of technology side. One of the interoperability factors of this rule is that information has to get into HL7 Fire 4.0 format. And so again, trying to standardize that language, but they are now looking to see how do we build in, some of these particular exceptions into that user-friendly electronic language.
What would you advise people to do in the meantime as we wait for Epic and other EMRs to work through these issues? If people are getting direct requests and they don't have an easy way to comply through their electronic health record?
So I think, and I'll have to check some of the, FAQs on the ONC site, but, it's not required that it be disseminated through an EMR. So finding another, electronic way to share the test results or the particular information that the patient has requested is really what's necessary. And again, looking at this USCDI sort of parameters, which includes patient name, sex, information like that, that's held by the provider. And if the provider doesn't have the information, you're obviously not required to create or produce it. So we can look at, what is the, information in that USCDI sort of standardized format. And I'm sure there are some FAQs around how do I have to provide this to the patient. But it does not have to be in an EHR. So I think there's probably, some workarounds there. Obviously that would be easiest, but doesn't have to be.
Do any of you have a feeling about how much education has been given to the public about this law and how often these requests will come in? Is that evolving as well?
Yeah, I'd say that's evolving. I'm not sure how much, I think, again, it's to Cori's point, it's a lot of education that the healthcare providers need to be providing their patients to make them aware of this, and their ability to access to their to their health records, because I think, not a whole lot of people probably are aware. I mean, I haven't seen a lot of PSAs or anything out there. So I think it's probably not a lot of folks are aware of their ability to access this, unless you're going to a practitioner or provider that's been, ahead of the curve and has had these portals. I've gone to imaging centers before and certainly have been able to access certain imaging in kind of real time. And so I think some providers have been ahead of the curve, and they inform their patients that they can access this information through these portals. But, from a general, public standpoint, I don't think many people are probably aware of this.
Although I imagine that will be changing, John.
It will be. Certainly as more and more people are able to access, and they're talking about it and their experience, and the good experiences and the bad experiences, and it will definitely be changing. And that's why I think that it's really up to the practitioner to really inform their patients that, they can, this is a new law, and they have the ability to access this information and talk through those issues.
For the genetic counselors in the audience, this is just another point to make when you're doing your pre-test counseling, and also another point in how important pre-test counseling and informed consent is, which we are trained to do and are very good at. So you may work with your EMR to develop a smart phrase. I know I'm using epic lingo here. I'm sure there's other similar things for other EMRs that just remind patients that they may see their results, or they may have access to their results before their ordering provider does. And then to verbally inform them of that, just, hey, a heads up. We give all of our patients something called an after visit summary. It gets, we ask if they want it printed, if they don't have access already to electronic MyChart app, for example. And in that after visit summary is a blurb that every single patient at our institution gets that explains what the Cures Act final rule is, and what they might see if they log into MyChart, and what they're able to have access to. And hey, heads up, you may see your results before your provider has a chance to contact you.
Last question before we wrap up. Consent for somatic testing is currently not required by many labs. Is this something you anticipate a change in practice? Not sure that would apply specifically to the Cures Act. What are your thoughts?
Yeah, I would have to look into that. We only have one test in the kind of somatic space, but I think you're right. It's kind of a broader question as opposed to information blocking.
So I think one answer to that question would be that as somatic testing begins to reveal germline insights, that there will be an even greater need to make sure we have informed consent for that. We're coming up on time now, so I'd first like to thank our speakers for really being leading the path for us here and letting us know what we may expect in this evolving environment with the 21st Centuries Act rule. Things will be changing over time. For those of you who joined the meeting late, please know that you will be receiving a recording of this meeting within the next 48 hours. I know many of you are thinking about plans to make for your organization. We're going to send a transcript within the next month with some options. We've also linked to the NSGC fact sheet in the chat, so be sure to cut and paste that so you have access to that. And I'd like to thank Kim, Cori, and John for stepping up and speak to us about an area that is very broad and confusing and that we're all figuring out. So thank you so much for being leaders. I'm Ellen Matloff. I'm the president and CEO of My Gene Counsel, and thank you so much for coming today.